Welcome back to Making It Awkward. I'm your host, Jessica Wilson. Today, I bring you my conversation with Pablo Sarmiento, a family nurse practitioner with an infectious disease specialty, specifically HIV and pre-exposure prophylaxis, or PrEP, a medicine taken to prevent getting HIV. First, thanks so much to those of you who have shared feedback on last week's episode with Dr. David Wiss. Part 2 is coming next week and is my interview with another researcher, Molly Robbins. About halfway through my interview with Molly, I realized that the conversation about food addiction, eating disorders, and ultra-processed foods will be a 3-part series because there was no way I'd cut down our conversation to just be a part of an episode. For folks still interested in giving feedback on part 1 and now part 2, can email it to makingitawkwardpod@gmail.com by July 26th. In 2 weeks, I look forward to sharing the feedback I've gotten in email, text, comments, and DMs from y'all. On to today's episode. Pablo is my neighbor and was walking his dog Otis the day I saw the Ozempic ad from the New York City Soho Men's Clinic that was featured in my recent episode with Kent Thomas. Pablo and I talked about some other treatments the clinic provides, like salmon injection facials. Pablo wondered what a pillowcase would smell like after this treatment, which is now something I desperately want to know. Anyhow, after discussing the Ozempic ad, we started talking about queer sexual health, and he offered to come on the pod anytime for a chat. I was curious about PrEP research and HIV incidents, and especially any updated language I should be using, and HIV disclosure, all of which we get into today. I was born in 1981 and don't remember when I first heard about HIV. I do remember Magic Johnson sharing his HIV diagnosis in 1991 and some of the dialogue surrounding it, particularly that he was, quote, sleeping around. He retired from the NBA that year, then came back to join the 1992 Olympics basketball team known as the Dream Team. After those Olympics, he returned to the NBA, and a few of the players rejected this due to concerns about getting HIV if Johnson, say, had an open wound. At the time, I remember wondering if somebody could get HIV through sweat and would watch each game, nervous that he would cut himself or he would sweat on other people. I wasn't getting much information about HIV at the time, other than you can't get it from closed mouth kissing. I first properly learned about HIV during my health and driving class in middle school. The lessons by the elderly Mrs. Jameson were basically, don't have sex until you're with someone who has never had sex because you will get STIs and warts and herpes are gross and you will die of HIV. The mission was to scare us into celibacy. There were also random references to sex with Mr. Jameson, her husband, and our creepy PE teacher that made us all vomit in our mouths. I excelled at health class and the STI quiz. I walked away from that class believing I would automatically get an STI after having sex, which meant that even though I was on birth control and dating someone who also had never had sex, I marched right on into my OBGYN after the first time we did and told her I wanted to be tested for all STIs. She asked about my and my boyfriend's sexual history and told me that she wasn't going to waste my time getting me tested because I certainly didn't have an STI. I was honestly surprised at the time because that's not at all what Mrs. Jameson had told us, or at least what my brain had heard. Pablo shares how the field has continued to evolve and how teens are now talking about HIV and PrEP. A quick note that this interview happened on a day that was over 100 degrees in Sacramento. My podcast studio isn't very insulated and just can't cool down after it gets incredibly hot. So we recorded this at Pablo's dining room table just after his power went out. There's no video because we were sweating until halfway through when the power came back on. You'll hear his dog panting in the background a couple times, and rest assured, Otis is doing great. And with that, I'll introduce Pablo Sarmiento, a family nurse practitioner working in the Department of Medicine subspecialty of infectious diseases. Originally from Spain, he completed his graduate studies in 2010 at Samuel Merritt University in Oakland, California. Since then, he has been practicing as a family nurse practitioner with a primary focus on primary care and infectious disease, with a heavy focus on supporting the HIV-positive, transgender, and underserved Latino communities. He is responsible for Kaiser Permanente's HIV care and pre-exposure prophylaxis programs. Pablo, welcome to the show.
Yay.
Would you like to tell us a bit about yourself?
Oh, gosh. Well, I guess I'm here because I'm a nurse practitioner. Mm-hmm. I've been involved with the LGBT community in Sacramento for over 12 years now. Mm-hmm. I'm an HIV/sexual health expert. And you're my lovely neighbor and you wanted me to talk to you. So here I am.
Well, this started because I showed you the beautiful Ozempic ad.
Oh my God.
Yes, which was amazing. And then, I don't know, did I tell you that I went to go see the clinic?
Yes.
Okay, yeah.
And I did see your little brief
synopsis of that.
Synopsis of that.
Oh, that was something.
This was very brave.
I wish you could have been there.
I showed that ad. I actually posted a picture and sent it to a bunch of doctors that I work with, and no one could believe that the Soho Clinic, which is supposed to be represent the community, is actually doing this opposite shaming.
Definitely. Okay. How did you get into the work that you're doing?
I was very lucky because I'm a family nurse practitioner, and I started working at One Community Health, where I used to be CARES Clinic downtown. And I work with some incredible, infectious diseases doctors that they kind of saw that I kind of like to take care of the LGBT community. And they asked me, hey, Pablo, you want to learn a little bit more about HIV care? Mm-hmm. You want to, oh my gosh, we have this trans patient. We don't know what to do with them. I'm like, I'll take care of them. So it's kind of a little bit more like me liking that branch of medicine and just having this really amazing doctors that supported me through it. And then about 7 years ago, Kaiser heard about me and they offered me a position in infectious diseases, specialized in HIV medicine. Mm-hmm. And so that's kind of what I've been for the last 7 years. And I absolutely love what I do. So I'm very lucky.
Who are your primary patients right now?
So I have primarily is we have two main panels, which is a PrEP panel over 1,000 plus patients, and an HIV panel, people living with HIV with about 1,000 plus too. So, a lot of people.
Yeah. Let's talk PrEP.
Yes.
How does it work?
It's still amazing to me that people ask about it as if I didn't know I have access to this.
Yeah.
I have been prescribing PrEP for 13 years now. Fully on. PrEP consults happen on the day and you can start on PrEP on the day of. Mm-hmm. I mean, we do rapid PrEP starts. It is the medication, it used to be the brand name, used to be Truvada, right? And it's pretty much, up until a few years ago, it was one pill once a day. You take it every single day, and it prevents HIV infection close to 99+%. Okay. It is actually extremely difficult to get HIV on PrEP. Even the studies that were done initially in Europe shows that even people that only take 4 pills a week, they're missing a few doses, 96% protection. So it's a very forgiving medication. And it's very interesting right now because before people would get HIV and they didn't know about PrEP, but now everybody kind of knows a little bit about PrEP. Mm-hmm. So people that get HIV and have not had access to PrEP is a very sad diagnosis, right? So but it's readily available.
Which populations are primarily focused or studied for PrEP?
For PrEP, we've always had, and this is more studies, right? In sexual health, people with HIV, etc. Gay men, cis men, and trans women. We always have less trans men. It's very interesting. It was very, very difficult to recruit, but primarily trans women and cis gay men. You could tell.
From research, is there a difference in effectiveness for PrEP?
There is a little bit of effectiveness, yeah. In trans women, we do know that the use of estrogen can lower slightly the effectivity of PrEP because of decreased concentrations of Truvada, the medication, in the blood. We don't know how significant this is, so we tell trans women to take their medication consistently, try not to miss any doses versus gay men who can miss a dose here and there. And also, we do actually now have a way of taking PrEP intermittently, where you can take it only when you have sex. This is called, we call it 211 on-demand PrEP. This is for people that don't want to take the medication once a day because maybe they only have sex once a month.
Sure.
So they just take 4 pills in a very specific way. Right before they have sex, and then 1 pill after, and 1 pill after that. Okay.
211.
Okay. Yeah, you double dose, you have sex.
Okay.
It's a little bit less effective. It's like 97% effective in preventing HIV, but it's still 97% effectivity is like way above what any other type of prevention. So, and it's very popular too. People are now they can do daily PrEP if they're very active, or they can back out of it and just do on-demand PrEP if they feel dry spells, they don't have much sex, but still do a little bit of PrEP instead of like no PrEP at all. So back to the question you asked me, trans women cannot do 2-on-1 PrEP because of the decrease in effectivity, right? So there are for different groups, sometimes we do adjust, we do tell people how they should do PrEP based more on the pharmacokinetics of the drug, but it's still very effective, like super effective.
Where's the research on cis women right now?
Yeah, where is it?
I don't know.
No, I don't know actually either. We want more research. We're actually been talking to the pharmaceutical company too, and there's very little research cis women and even heterosexual men as well too. And the effectivity of PrEP, how they use it. So there is lack of research now. With the new Truvada, I hate to say the name of the brand name of the medication, but there's a new reformulated Truvada in the market called Descovy. That is the brand name.
Okay.
It's very expensive. The pharmaceutical company really wants us to prescribe it because it's a very expensive way of doing PrEP. But there may be some more research on heterosexual, couples and cis women, etc. But we do know that PrEP is effective. And when I prescribe it, I don't look at cis women differently than cis men. I just prescribe it. If you come to my clinic and you say, I think I need to get on PrEP, you're gonna get PrEP.
Yeah.
I don't ask you questions about we don't do that anymore. We don't do go through detailed sexual or histories. We just, if you need it, if you're in that clinic because you need it, you just prescribe it. You just give it. It's a very safe medication too. We know after 13 plus years of prescribing it.
Sure.
There's no long-term effects. It's safe.
So similarly with the dearth of research on cis women, where is the research on HIV and cis women? And how does the research landscape look for HIV?
I actually am a sub-investigator. I do research as well.
Okay.
I work with this incredible doctor called Dr. Flam, who's an eminence of HIV medicine in the West Coast. And we do have, you got to realize that about 25% of new HIV diagnoses that we see are heterosexual men and women, so there's the cis women, come into that group and primarily, and they're very difficult to recruit for studies because there's also a smaller group, right? And when you do
smaller group?
Well, smaller group in the sense of I don't have that many women in my panel.
Okay.
Right? And then you're trying to kind of put them into criteria for studies and they just don't always qualify as well, right? Because a lot of the studies are focused for cis men, etc. So some clinical trials will actually specify and they will ask you to actually try to get more cis women or trans men or because they're trying to kind of find out more the risk index for these type of groups. But again, they're difficult to recruit because they're not the majority. Now, if you think about, for example, trans women, right, who have 49 times more likely to live with HIV.
Okay.
Right? And yet, if you look at my panel, probably less than 2%.
Okay.
So I'm not identifying this huge high risk group that's out there living with HIV. There's almost 1 in 2 trans women identifying a certain woman that they can't have HIV. And I don't have that many. So that's that gap right there, right? Then you try to, enroll these 2 women in a trial. It's difficult. It's a lot of still socioeconomic discrepancies of groups in HIV.
Yes. And you think the research discrepancy is just based on sample availability?
It's primarily sample availability, I think. Because, if only 25% of my panel are cis women, right? So again, there's just a smaller sample to pick from to use into research. You know what I mean?
I do.
Not only that, when you're doing initial criteria to enroll patients in research, half of them fall out.
Sure,
that don't qualify. So you start with a smaller sample that gets smaller and smaller and smaller. Right? Like, for example, Black women, particularly with HIV, are particularly, almost nothing on clinical research, yet they're there.
Right.
Actually, if you look at, I think the data from the CDC from 2021 of the heterosexual people that get diagnosed with HIV nowadays, which is about like 26% of people, 66% are heterosexual, like Black men and women. Right? This is like a large number when you start kind of looking at the individuals, and we just don't have the representation of them in research.
What do you think are the systemic things that we're missing when it comes to that, but also HIV? So a lot of focus is on testing and testing and testing. But I'm wondering, like, what is a conversation about systemic concerns, or I don't know. I'm just.
I know what you mean, and that's a gold question, right? Because like right now, the number one group of diagnoses right now are just like Black and Latino young kids, 18 to 24. That's all I see in clinic right now.
Really?
Lack of education on HIV. We did talk about people should know what HIV is, but these kids just don't really. I don't think they were exposed to what happened 10, 15 years ago.
Yeah.
Or they've heard that their friend is HIV positive and he's just taking one pill once a day.
Yeah.
So I think the fear is less. Oh. And then they'll come to the clinic and they just don't understand what it is. You're going to be immunocompromised for the rest of your life, even though I'm going to give you this medication that's going to keep you pretty much healthy.
Yeah.
There are consequences to being immunocompromised for the rest of your life, right? COVID, et cetera, right? So I think the other thing is, we've heard this many times, they just don't, lack of trust, right? You don't see buses advertising PrEP with a Black kid or a Black woman in the face, right? Some white kid or whatever.
Yeah.
The gay community in itself, advertises to white gay men primarily, right? I mean, so I think there are gaps in like trying to reach these groups individually. Right? Like I particularly, because I noticed this in clinic, I paid more attention to Black and Latino kids. Like I'll do extra work to make sure that have they picked up their medications? Are you having issues with transportation? So you kind of dig a little bit deeper with them if you want them to engage in PrEP. The studies show that they are the most likelihood to start PrEP and drop at 3 months. So they also have high dropout rates. So I have this PrEP coordinator that we try to focus on these groups to make sure that at 3 months we always do a follow-up call. By the way, electricity is back.
I was like, are you cooking something? Okay.
Oh, thank God. So, so we do, I see it, right? So I kind of work a little bit harder in these groups.
So are you an HIV clinic, as in people get referred to your clinic, or are you like first stop where people will show up to be tested?
Yeah, so no, I'm the specialist that if anybody gets diagnosed, they come to me first. I'm the one that usually will disclose the diagnosis. I actually monitor every HIV test for the institution that I work for every morning. And if I see a positive, I will contact the doctor that ordered and say, hey, did you need help disclosing to this patient?
Got it.
I can do it for you if you're comfortable doing it. And then immediately send them to me. We have a turnaround of like 48 hours for them to see me. So it's because I'm a specialist, so I have lots in my schedule to see these patients right away.
Sure.
Yeah.
So what's that kind of conversation like?
This is kind of make it sound weird, but I actually love that part of my job because people come in a very vulnerable state. Yeah. And you hear horror stories of people being told over the phone, access. So for them to be able to have hour visits with me, so they can sit with me, we can talk as long as they can. I allow them to bring family members if they need to. I tell them about this. So they're very long visits, but they're very rewarding because I think it's a pretty transitional time for people. They'll remember that day for the rest of their lives. Yeah. Most of them will. So I pride myself in being there for them in that particular moment and making as easy as possible.
Do you see adolescents as well as adults?
Yeah, I do 13 years and up.
Wow. What are those like with teens?
A lot of in-person, a lot of follow-ups. Yeah, a lot of confidential issues with parents.
Yeah.
Talking about sex and do they pick up the Truvada? Is mom with them at the pharmacy?
Yeah.
Unlabeling medication. So we do all these kind of things to also promote PrEP also in youth as well too.
Yeah. Did you say you would unlabel?
Yeah, the pharmacy will actually kind of cover label.
Yeah.
We actually forfeit any like co-pays for medication, so that way you can just grab them because there's no issues with like mom's credit card. So we do have some pretty cool teenage like PrEP prevention programs because that's the worst. You get diagnosed at age 17 with HIV, not a chance, right? So we try to, good.
How do teens get to you to start on PrEP? Like they heard from so-and-so and then they show up or?
We have a pediatric infectious disease specialist, a physician. He's amazing. And he knows that I don't mind doing, because I'm 18 and up. I practice medicine 18 and up.
Okay.
But he knows that I don't mind doing like 13 and up. So he'll send them to me. And because I do so much PrEP, I'm super comfortable talking to teenagers about PrEP. Yeah.
So how do they end up with you, though?
Oh, so either the primary care physician refers them to me, or they refer them to the pediatric ID doctor, and the ID doctor calls me and is like, "Hey, Pablo, I have this 13-year-old kid. You want to?" I'm like, "Sure, I'll see him."
Got it.
So it's a corroborative back and forth. But I think I've been doing PrEP for so long. I direct the entire PrEP program at where I work, so they just send them to me. It's fine.
Yeah. I'm still stuck on this teen situation.
Are you wondering why this is not like in primary care? Is that why you're wondering?
No, I'm like, how do teens I'm like, are teens just talking about this and like then they
so it requires the attention of the primary care physician that's in there, right?
That's how.
Right? So it requires, and this is also ongoing. I told you I teach residents, right? About sexual health.
Yeah.
Like talking about sex is always left to the end, right? And it shouldn't. It's just like some of us call it like the sixth vital sign, right? Where it should be talked to and brought into conversation with any other questions about social history, family history. Do you have sex? Who do you have sex with? Very casually. Or even warning patients, like I say, hey, we're going to talk about sex like openly. I want you to be super comfortable. So I integrate it where it's like easy for people to talk about sex. But when you do that, people open up. That's just my experience of it. And then over time, you develop this incredible close relationship with your patients, because no one has dared talk to them about this. And they're more willing to show up. They're more willing to participate in their care. So
got it.
Actually, talking about sex it's a very close, it's a great way to get close to your patients.
Six Vital Sign. I think that's the title for this.
Oh, there you go. That's cute.
Talking about sex. I love it.
That's what I call it. I don't know.
I think it's great. Dear friend of the podcast, Whitney Trotter, was curious about the overlap of patients with HIV and eating disorders specifically. She has worked in a clinic where years ago she would see gay men who were very invested in binging to bulk rather tan look wasted.
It's a very interesting topic. It's kind of nebulous too, because as these patients were wasting too, there is a idiopathic path of HIV which can actually lower testosterone levels. We don't know how it happens, but so in the 80s and 90s, a lot of people living with HIV would request to get their testosterone levels checked, and a lot of them ended up with high levels of testosterone, and they would take advantage of like work out and become very, very buff. So that got diluted. This wasting look got diluted, but this guy's looking super buff.
Yes.
So you couldn't tell anymore whether HIV or not. Right? Fast forward too, as the medications get better and better, and we consolidate them and they're one pill once a day, and integrase inhibitors, which the specific class of medication comes into the market, guess what this medication costs? Weight gain.
Oh.
So this is
interesting.
Very interesting. So now we're actually in the other facet, where it's your HIV, are you on an integrase inhibitor? You're going to gain weight. If you're a diabetic, it's going to make your diabetes worse. So actually, It's very interesting. We're kind of a little bit on the other side where you cannot actually, none of those medications call this lipodystrophy anymore. So you can't tell somebody that's an HIV mess because they have the hump, the fat hump or anything. None of that stuff happens anymore. And a lot of those patients, I mean, they're in their 70s and their 80s, but they're not like out there in the street where people used to identify them, right? You don't see that anymore. Yeah, it's interesting right now. It's actually a little bit kind of like the opposite. I'm actually dealing with issues with people gaining weight. Also, I think the medications are so good that you put them on meds and people get very healthy. They've been very sick for a time and suddenly they put on weight. So people look healthier and healthier and healthier with HIV. You cannot tell at all somebody has HIV. It is unfortunately like mainstream and like totally normalized in the gay community in general. Yeah. I think, right?
Okay.
People don't want to talk about it. It's so normalized that people don't think it's a problem.
Okay.
I ask questions, and some people will actually tell you about them. But in general, I mean, with a panel of like thousands of patients, I don't routinely have patients asking me for help because they have issues, with eating disorders. So again, it's just not talked about. You see it. You see people's fluctuation on weight all the time. You see the obsession with the six-packs.
Yeah, abs.
All that stuff. But now you see the push back from like, now the daddy types are coming in, right?
Tell me more.
Yeah, so this is where like people pulling away from looking for the gym bun, but like more like the dad bod, right?
Got
where
it.
you have a little bit of a gut and you don't shave your hair. And it's more like they're masculinizing like gay men a little bit more. So it's very interesting. You can see the term is not daddy anymore. It's zaddy with a Z. All that stuff it's kind of interesting how these things move around. I don't know what causes it, but there's definitely possibly a little bit more pulling away from this like perfect gym body that's what everybody looked at.
Okay.
For many years, which is good, I guess.
I need more information now. I'm excited.
Yeah.
Sounds like a good episode. So, you don't bring up eating disorder stuff. They don't bring it. It's just like we know this is happening, but we're not going to talk about it.
Yeah. So so you definitely address diet with most of your patients. You have to be careful how you pose a question of what's your diet like, right? Or do you will never ask a question like, do you think you have an eating disorder without information given to you primarily? So again, I think it has stigma to it as well.
Yeah.
So it's not something that you initially
jump into.
But to say the least, I do have a registered HIV dietitian that works with me.
Cool.
She sees every person that I see first time. She comes behind.
Aww.
And she pretty much comes in and she says, hey, I'm the registered dietitian. I'm an HIV specialist. If you have any questions about setting some goals, weight gain, weight loss, I'm here to help. So we do offer this type of kind of like, multidisciplinary kind of in the background type of thing. And patients can engage. Some patients engage rapidly, other patients.
Sure.
But yeah, I mean, it's a topic that's interesting. How do you ask about it, right? Yeah.
Speaking of those clinical conversations, how do you talk about disclosure and what are the conversations about disclosure happening in the community like?
Yeah. So are you aware of the concept of undetectable, untransmissible?
Let's do it. Just so people are listening.
Yeah, so it is now well known, 3 major clinical trials around the world. With this study, heterosexual serodiscordant couples and homosexual serodiscordant couples that follow through hundreds of sexual acts, not a single transmission. So that if people are HIV positive, they're on antiretroviral medicine and they're undetectable consistently, it is impossible for them to transmit the virus. There's actually not being a single documented case of transmission. So this is changing the dynamic of, we're going to have sex. Are you positive? I'm positive, but I'm undetectable, right?
Okay.
It's taking a lot of the fear of having sex with people that live with HIV. So there's like an ethical part of it where, like I tell my patients, it's difficult to disclose to everybody, especially people that are not significantly close to you, that you're positive because people talk and there's still stigma around it. So should they disclose? Yes.
Okay.
Ethically.
Okay.
Morally.
All right.
Do they have to? No.
Mm-hmm.
If I'm HIV positive and I'm undetectable and a one-night stand, will I disclose my status? Most likely not.
Oh.
I know deep in my heart I cannot transmit this to anyone. So it's kind of touchy and iffy, right?
Yeah.
Of course, there's that part. But I think people have the right to disclose or not disclose. And the other partner is the one that should be on PrEP and keeping themselves safe. If they're going to have unprotected sex with somebody that they don't know either. So It goes both ways.
Yeah.
I think it goes both ways,
Do you see one day where the stigma around HIV will not be as intense or exist much at all?
Yes. But just like everything, I think it's one of the last things that's going to go away.
Yeah.
Unfortunately. But things like the CDC campaigns for U equals U. You see them on buses. So just U equals U. Yeah. They're actually there is like the undetectable equals untransmissible.
Got it.
They're promoting this. So you see people with HIV as like normal people with a virus that's undetectable. They can't transmit it. So it's when that type of, how to say, advertising, but support for the community happens. Yeah. I think the stigma will continue to go down, right?
Cool.
But now you're talking about accessing all these trans women with HIV. How do you get to these groups, right? That's the tough part. And then, like I told some of my patients, like you diagnose like a gay boy with HIV. It's like, okay, they know it's hard. And then you diagnose a black trans woman with HIV, a 22-year-old with no job, house insecurity, no car, and they're there to see me for one visit. And I have a repertoire of things that she needs to do for me, right? And most likely I'm not going to see her for another 6 months. So there are different groups, and the stigma is different. It's going to be a work of different groups, I think.
Yeah. All right. So what language do we need to know today when having conversations about PrEP and HIV? Because things are different and changing in the words and language that we used in the 90s. Yeah. Not now.
So, undetectable equals untransmissible.
That was good.
So that's a good one. The other one is like, who should be on PrEP? Anyone asking for it. Period. Okay. So that's something that I teach tremendously. If you look at the CDC guidelines for prescribing PrEP, there are tons of bullet points.
Got it.
Sexual health workers, you don't need any of that stuff anymore. If somebody's asking you for PrEP, prescribe it. That's my advice.
Okay.
So that's another one where it's kind of like more, just it doesn't matter who they are. Cis women, it doesn't matter. Prescribe PrEP. It's effective.
Okay.
No, I'm 13 years into it.
Okay.
But other things should be STD testing. We should do a talk about just STD testing by itself.
Why not?
STD testing, who, when, how often.
Okay.
That's a huge one. DoxyPEP, which is taking antibiotics to prevent HIV. STDs is huge right now.
Okay, also, that one's new.
DoxyPEP?
To me? I'm just...
And again, no data on women? Oh, you're going to love this one.
So is language people living with HIV positive people?
I say people living with HIV. Okay. It's a great way to refer to them.
If clinicians are having conversations or wanting to ask people if they're HIV positive, is that like the sentence or?
Okay. So if I was to ask somebody, I would ask them, have you ever been tested for HIV before?
Okay.
Have you had an HIV test before? That's a great way to ask a question.
Okay.
By the way, this is also important information for those who need to talk about testing. It is 2024. The CDC guidelines is that anybody aged 13 to 65 should have one HIV test in their chart no matter what.
Oh.
So HIV testing now is opt-out. So me as a clinician, if you come into my clinic and I said, let's talk about your diabetes, and I go, have you ever had an HIV test before? And you said, not really. I can just throw it in unless you decline.
Okay.
So it's opt-out. So now the ERs are testing. So this is also our attempts to, again, you find people that are positive, you put them on antiretroviral medications that become undetectable, they don't transmit, and then you have this other group of PrEP patients, and you end the HIV epidemic. That's there's two groups, making people undetectable and PrEP. I mean, actually, if you look at number of infections in San Francisco, we've had 500 men getting HIV every single year for 15 years. It didn't matter what we did, sexual health prevention, condoms, and then PrEP hits in 2013, and we're down to like 300, 250 infections per year, going downward. So we know PrEP is a huge catalyst of lowering infection. So this stuff works.
Okay. You're like spokesperson. Well, literally, actually. So asking someone if they've ever been tested and then the follow-up, they say yes. Will they just offer I'm HIV positive?
Or like, again, so for me, it's so natural, right? To say, have you ever been tested? It's like, no. Would you like me to test you?
Yes.
Or, do you want to talk a bit about your sexual health at all? Do you have sex? So for me, it's very natural to integrate this conversation because I do it all day, right? I will always offer an HIV test to even people that said I've never had one. They want, no, but I'm single. I haven't had sex in like 20 years. That's fine. Let's just do one. Let's throw it in. It's good for you to know that you're negative. It's second nature to me. I don't understand why people have such issues.
On, say, a questionnaire or in an assessment, kind of just ask somebody to click a box if they're positive or negative, or
no, you can't do that because that's disclosure, right? So that's actually probably against the law to
tell me
So especially California laws, right? You under no circumstances, anyone should disclose like somebody else's status without that person's permission, right? There are laws that kind of like...
Sure.
Now, laws where people go to jail, people ask me all the time, right? Well, if my ex-girlfriend goes around telling that I'm positive, right? Or the laws that he infected me on purpose, those don't exist anymore. Where like people are just actually that people are going to go to jail because it's very difficult to prove that one person infects another person. You'll have to draw blood, this, you know what I mean? Like, you start violating all kinds of like human rights by doing this. So again, it all starts with, if you're promiscuous, if you're having sex with people that you don't know their status, you should be careful, right? So, but, huge fines. Actually, like for example, me walking on the street and one of my patients approaching me, I can't say hello to them.
For sure.
Because even just the fact of saying hello and I'm an HIV specialist. That's actually could disclose their status, right? So, and there are some very, very HIPAA laws regulating this $150,000 fees for disclosing people's statuses. So, still, I'm glad that it is like this. Still, is their diagnosis and yours for you to know. That's it. You only disclose it when you want to. I think it's very, very powerful.
Okay. Anything else you want to add other than get on PrEP?
Yeah, I think like people need to understand more that HIV is not a deadly disease anymore. It's becoming very much easier to treat, and that people with HIV are like just safe, normal people like everybody else. Well, what was the question again?
Oh, I just asked you if there was anything else you wanted to share.
I wish people becoming more educated about this type of stuff. I don't know. In general,
Yeah, being less of an asshole.
Yeah.
That's what it comes down to a lot for me. Like,
don't being so
much.
Like I told you, with HIV, heterosexual people are a disaster of a diagnosis. It's a fucking nightmare. You walk in there, they're lying, they're in denial. You then, sometimes, especially black men, right? Their masculinity. It's something they've been holding on for many, many years in the United States, and you bring HIV on top of a heterosexual black male, they lose their shit in clinic.
Interesting.
So everybody thinks they're gay, and
that was going to be my question.
You see what I mean? So it's like each group has this different stigma kind of things that you have to deal with. It's very interesting. Anyway. I was just thinking about that. I was thinking of particular people actually that I'm like, oh my God. It's a disaster. Or my husband cheated on me all my life, so I went out one time and got HIV and women. It was devastating. crying and crying, and I'm never gonna be able to have kids. I'm like, yeah, you're gonna have kids, it'll be fine. But you see, like, it brings people like this wave of stigma. Each bringing their own wave of stigma. It's kind of it's very interesting.
So I'll say here, if folks have questions for Pablo, please email them. Thank you for coming on.
Of course. Thank you for having me.
Yeah.
Thanks so much to Pablo for coming on and sweating it out with me for this conversation. I definitely learned a lot. I'll get to continue the conversation about HIV because a trans colleague of mine is an HIV researcher who has also offered to come on the show and speak to what is missing in the research and why. He and I will also chat more about HIV disparities, particularly in Black cis women and trans and non-binary individuals, and how a lot of it is connected to other conversations about systemic disparities we've talked about on this podcast already. His interview should come out in fall. And then another reminder that you can still submit any feedback on last week's episode with Dr. David Wiss until July 26th. I look forward to your thoughts and hope you make it awkward. If you have 21 seconds to spare, I'd love for you to rate and review the show. It's the easiest way to support us. You can also become a sustaining Patreon member and support the work of the fearless editor of this podcast, Jen Jacobs. Thanks so much in advance. This has been Making It Awkward. I've been your host, Jessica Wilson. This podcast is a production of The Body Politic. It is supported by Patreon members like you and the legacy of Sacramento Outboard Services.